it should be well structured. There should be less data, but informative. There is no need to write everything. Every day, you don't need to write vitals table. If there are vitals that you need to be monitored and changed, write that down. The other nurses might probably write down the daily vitals in another place. The content should be organized. There is no set way in which to organize it, but it should be understandable by the next person on your shift, by the referring doctor, or even by yourself later on, by the patient also later on. So it needs to be logical and consistent. Same thing, simple, complete, and accurate. Legible. So I cannot speak enough about this. There is no hard and fast rule that doctors need to have bad handwriting. This is an ongoing joke. And there are times when people have asked me if I'm a doctor or not. So I'll give you an example of what my handwriting looks like. And that's why I'll tell you why it happens. It should contain basic information. Yes, vitals do help because most of the time, those are the things that we are going to monitor on a daily basis. The problems that the patient has, past relevant history, progress notes in the SOAP format if possible, and what are we planning to do, again, a part of the SOAP format. So talking again about the joke, not necessary to write like an Egyptian. So there's this little joke about, I can't read a thing, they must have been doctors. But this is me. I've been practicing for around 20 years now, and this is how I write. Not the perfect handwriting, but at least I can read it. My colleagues can read it, and my patients can read it. I have mentioned my findings.
It's very clear, doctor. It's really beautiful, though.
Thank you. So this is a real life patient of mine. I've covered the name. I have done a little bit of a mistake here. I've done a little bit of overwriting, which I should not have done. But then day-to-day things happen. All the information is there. The patient is a known case of hypothyroidism. These are the findings with all the old reports. He has just come for a follow-up. He feels good. His weight is okay. And it was done online, so I couldn't examine him. The symptoms and signs, nothing. He said I was fine. So what did I tell him? I told him to continue his thyroxine, his thyronorm at 150 micrograms, and continue till when? Till I see him again, which would be maybe October or November. So it's almost time for him to come and see me again. And I would like to see a repeat of his TSH, nothing else at the moment. Obviously, if he needs me, he's absolutely welcome and definitely should come and see me before that. So that's my information that I put over here. So where do we need it? I have quite a few slides on NABH guidelines, which I am hiding at the moment because we really don't need to know them. But whenever you have a clinical audit at your hospital, your clinic, your parent center, there are some things that we need to know. Why is it required? This is taken from the NABH website, where it says that, like all quality management systems, documentation is an essential component of the accreditation process. The standards require proper documentation. The documentation needs to provide correct, complete, current, and consistent information. So this is kind of parroting what I've already told you. The documentation effectively meets patient and stakeholders' requirements. So that's all the reason why we need to keep our documents ready for all kinds of audits. So going directly to slide 36, guidelines. This is a model prescription that is given out on the Maharashtra Medical Council website. Try to stick as much as possible to these points. Your name needs to be there, your qualifications, your registration number. Doesn't need to be repeated. If you've had it, if got it at the bottom of your prescription, that works too. Full address if possible, contact number, how at least the patient is going to contact you. A prescription serial number might be a good idea. The date, patient's name. Now, if you have a hospital unique ID or you have a database, you don't need to write the address and phone number again and again. Just an ID number works. Patient identifying information, the gender, the age, weight, and other vitals. When you write the name of the medicine, these are little pointers. I will talk about it again. And then you can write that, yes, it's okay to get a generic. Sign, put a stamp. If stamp might have all the information, so you don't need to put it again. And then you might want to put dispensing information at the bottom. This is especially important for Narcotics, it's especially important for psychiatry medications because the number of times the prescription is refilled, how many times you can do it, how long this prescription is valid for, these are very important pointers. So I'll explain what I've just explained again. Write the generic name as far as possible. I write as far as possible because when you're writing a multivitamin, it's practically impossible to write maybe 20 different vitamins and their compositions and all. So you can write maybe the brand that you like, something that works, and then write multivitamin on the side. If you are writing a brand name that you know that works, at least write what the composition is on the bottom, so that in case they don't get the exact same brand, the patient is not without medicines until they can contact you. Preferably write in capital letters. I say preferably because I fall short on that. If I write in capital letters, I write slowly. So I write clearly in small, but people with a little issue with their handwriting, it's better to write in capitals because capitals are usually easier to read. Avoid using too much of abbreviations. You might find it easy to quickly write OD, BD, TDS, QID, HS, but what does that mean to your patient? So easy to just write once a day, twice a day. It's common English. If you want to write in vernacular, you can do that. You can write OD, then mein ek baar. Likh sakte ho. If you have the benefit of having a typed prescription, lovely. Otherwise, somewhere where the abbreviations, if you're writing them, at least they're explained also. Avoid overwriting. Like I said, I did overwrite on the patient's age. So avoid that. You are human, you will make mistakes. So cut it out and write it again on the bottom. Write the dose, the route, the frequency. This is especially important for inpatients because in outpatients, most of the time you're going to give oral medications, but in patients, there are so many different routes. You know that very well. How often? And then instead of writing just SOS, better to write as and when required, especially when the patient is taking the paper home. Not everyone might understand what SOS and stat and everything means. Write the strength, again, extremely important for inpatients where you're titrating something. 100 micrograms and 100 milligrams makes, you know how different it is. So write the correct strength, the correct unit. Write refill information. When is the patient supposed to buy the medicine again? When are you supposed to restock? These are important points that we need. So guidelines continue. On your first checkup, and just check if it's there in the past history also, an accurate and complete account of all the ongoing medications, because we want to avoid medication cross reactions, adverse reactions. We want to avoid polypharmacy where the patient is taking the same medicine, different brands. So we need a detailed medication history. We need to include allergies. Paracetamol given all the time, left, right, and center, and it's mostly very, very safe. But I have seen people with paracetamol allergy landing up in the ICU with Stephen Johnson's. So please include your drug allergies, especially important ones. Sulfur penicillin, we know that, we write that commonly, but just ask about anything else. Remember to mention details of continuing past medicines in discharge summaries and follow-up prescription. So this is something that I've seen very often, that a patient goes to someone or has been admitted and only the current treatment information is given. So what happens? The patient goes home and thinks that, oh, I think I've been to the hospital and somehow the doctor has cured my diabetes and hypertension and I don't need to take those medicines anymore. All I need is to take my antibiotics for 5 days for this procedure that I've had. And then the wound doesn't heal. And then you go back and find out that no one told them that you're supposed to continue your old medicines and keep in touch with your regular physician. Lifestyle advice, you will be obviously explaining, but put something in writing. Because unless you put it in writing, the patient can always turn around and say, "Aapne to bataya hi nahi tha." And then what? So lifestyle advice should preferably be mentioned and noted down. When to follow up, when to come back. Do you need the patient to come back with more investigations? When and how to obtain urgent care. These all should be mentioned in your OPD papers in some way or the other, and definitely in your IPD discharge papers. and refrain from prescribing medicines from other systems of medicines. See, as modern medicine doctors, as allopathic doctors, we will not know much about other systems, like they would not know much about our systems. So it's better to avoid writing some lifestyle supplement or Ayurvedic supplement. I have nothing against them. There are some which are really very nice, and if you know about it, you can, but avoid. MMC asks us absolutely not to. Now things are a little diluted because a lot of mixed pathy is coming up. But still, logically, if you've not studied about it, if you've not learned about it for all your training, it's better not to write about it. So one small case discussion, again, it can't be a one-on-one. I mean, so I want you to write down in your notebooks or in your chat box about this. I'll just talk about the case. Mr. Swami was a smoker, didn't exercise, and he had severe chest pain, went to the hospital. Once he reached the hospital, people told him that he was having a heart attack, directly was taken to a cath lab and told that he would have a stent put into his heart. He was not well, so he just said, oh, do whatever you can to make me feel better. Family members said the same thing. After the procedure, obviously he felt better, got discharged, all good, but he has this long list of medicines. So this Mr. Swami has not been to his family physician, or probably does not have a family physician, was not given proper lifestyle advice. And he got discharged, long list of medicines, confused, doesn't know what to do next. So what does Mr. Swami need to know? Write down pointers. You've got the answers over here. It's like a comprehension that we used to have at school. If you look at the discussion, you have the answers. What does Mr. Swami need to know? And as a family physician, how could you help him know what he needs to know? Right?
Okay, so there are two questions here. That what does this particular patient, Mr. Swami, need to know? And the exact or the summary form is already given. I think you can take the answers from in there, because the patient already had heart stent operation done and chest pain was there. So what and he has a big list of medicines. What exactly is a family physician role here, because he has contacted one of them? So what do you think should be the answer? Please write it on the chat box. We'll be taking the question.
And then we'll discuss at the end. Okay.
Absolutely, doctor.
Right then. So this is towards the end of my discussion, and fortunately or unfortunately, I do talk very fast. So I'll go with a slow, nice little joke. So once a male doctor was traveling by a train, and a very lovely lady comes and sits opposite to him. The doctor is very happy about it. The lady keeps smiling, and this makes him even more happy. Then she goes and sits next to him, and he's really overjoyed this time. Huh? She leans forward and whispers in his ear, hand over all your cash and cards and mobile phone, else I will shout loudly and tell everybody that you're harassing and misbehaving with me. The doctor stares totally blankly. He took out a paper and a pen from his bag and wrote. So he documented, I'm sorry, I cannot hear or speak. Please write on this paper whatever you want to say. And the lady complied. She documented and gave it to him. The doctor takes the note, puts it in his pocket, and then stands up. And very clear tones, he says, now shout and scream. So see how important documentation is, right?